Thank you so much for coming on the podcast, Dr. Hannah. For the people who don't know who you are and what your sort of history is in academia and as a doctor, can you give us a little bit of an introduction?
Thanks so much for the invite. So my name's Hannah Short and I'm a GP by training, but I've done further specialist training in menopause and premenstrual disorders. I didn't actually go to med school until I was 27, so I did a graduate medical degree at the University of Cambridge, having done a human sciences degree at Oxford previous to that. So I didn't start my career in medicine until I was qualified in my early 30s. And initially I wanted to be a psychiatrist, but long story short, I'd left my psychiatry training after the first year to go into general practice because I felt that I might have more of an impact. It felt like we were seeing people at the very extreme end in psychiatry, and I wasn't, I suppose, that happy with the way that we were able to provide care. And I mean, some of it's to do with funding, obviously, in the NHS and difficulties. But I wanted to see if we could kind of help people before they got to the stage of needing inpatient psychiatric care. Very long story short, I had my own health issues relating to kind of hormonal health, having a history of endometriosis and also a premenstrual disorder. PMDD wasn't a term much in use at that point, and I'm not sure if that's what it would have been classified as, but I had very significant premenstrual anxiety and low mood, and I ended up having a hysterectomy and my ovaries removed when I was 35. And it was, I suppose, that experience, and even though I was under a very good team, realizing that in medicine we're not really equipped to deal with this so much in younger women, and in terms of when you enter an early surgical menopause. But also, I suppose, having had your ovaries removed at such a young age, it just, you think you don't really want to end up having such significant treatment if we can prevent that happening. I'd love if we can get to a point where we're not removing part of the endocrine system of young women for a benign condition. Obviously, in cases of cancer, it's going to be necessary, for example, but in my case, I don't know, maybe it was necessary, who knows? We can't change things, can we? But and there have been some positives. I've been better, I suppose, since the surgery, but it's been quite challenging. And it's because of my own experiences that I ended up training as a menopause specialist. And now I work exclusively in female hormonal health and probably see 50% menopausal health concerns, 50% premenstrual.
Wow, that's incredible. And actually, your journey is not too dissimilar from mine, where I was a creative originally. I trained as an actor and a voiceover artist, and then when I developed this condition and I started to do research and find out what it was, I completely changed the trajectory. Now I'm studying psychology in the hopes
Wow.
I know, in the hopes that I can go and help other women like myself, because again, these conditions are still not spoken about enough. There still isn't enough research in the medical field or the science field about it. So I guess the first question is, what exactly is PMDD, premenstrual dysphoric dysfunction? What is it? And I know there are similarities between PMDD and PMS, and also what's the difference? How are they different?
Okay, so it's a huge topic, really, and I think there's debate really about what is classified as PMDD, what is PMS, but they all come under the umbrella of premenstrual disorders or premenstrual, conditions, which means that symptoms arise in the luteal phase of the menstrual cycle, so from ovulation to menstruation. So it could be for the entire 2 weeks, or it could just be a few days before menstruation, and symptoms should improve or completely lift within a few days of the period arriving. PMS stands for premenstrual syndrome, and it's also been called premenstrual tension, PMT, but PMS is probably the most common term used. And actually there are 150 kind of symptoms at least that come under the PMS umbrella. And they can
Wow.
include emotional, cognitive, and physical symptoms. So it could be, tearfulness, feeling a little bit low, but also, having a bit of brain fog, needing more sleep, and physical symptoms like breast tenderness, headaches, bloating, joint pains. PMS and PMDD. So PMDD stands for Premenstrual Dysphoric Disorder, and really it's more, the difference is really a matter of degree and severity and how severe those symptoms are. And with PMDD, whilst physical symptoms can be common, it's the emotional and cognitive symptoms that cause the most distress and can lead to dysfunction in the person who's affected in their life, whether their personal life, their working life, their social life. And even within the PMDD umbrella, it really is a matter of degree. So some patients will be, really, really struggle, but still somehow manage to kind of carry on some semblance of normal life. But it may be that they can get to work, but they have to put their social life on hold, or if they've got a partner and they've got kids, their partner has to take over childcare duty, all of that stuff. They look like they're holding it together, but it's probably taking all of their might. And then there are others who really are unable to function, unable to work during that period, unable to study, walk away from relationships. So it's more a matter of degree. It's not uncommon to see girls and women who have PMS, milder symptoms that are still potentially disruptive, and it do affect their quality of life. But that morphs into more PMDD, symptoms later in life. And we can talk a little bit more about why that may be. In terms of formally classifying PMDD, there are different criteria. There's the DSM-5, which is, the psychiatric kind of journal will class it as a psychiatric disorder, but ICD-11 will class it more as a gynecological disorder, and the criteria to be diagnosed is it's kind of halfway between them. Where how I come at it from a medical and clinical perspective is how is the person in front of me affected? Like, are these symptoms premenstrual? Is it affecting their life to such a degree that they are unable to function at work or school or home? And then I would be more likely to diagnose them with PMDD, because it can be a bit of a narrow window. Otherwise, you can miss people with very severe symptoms who don't technically fall into PMDD category. So it's a bit of a minefield. The Royal College of Obstetricians and Gynecologists in the UK classify like 5 different types of premenstrual disorder. But when it comes down to it, I suppose the simplest way is thinking PMS is more milder symptoms, and it could be that maybe it's the headaches or breast tenderness that's more problematic than emotional symptoms. With PMDD, it's very severe emotional cognitive symptoms with potentially associated physical symptoms. That and sometimes can lead to suicidal thoughts or suicide. That's the danger here, is that it is a life-threatening condition, because some people sadly do take their own lives or they self-harm. That would definitely be in the PMDD camp. And it's thought that around 30 to 40% of women struggle with premenstrual symptoms that would meet the kind of a clinical kind of diagnosis, but it's around 5.5, 6% of women, and those assigned female at birth, who will have a PMDD picture.
Wow, you have touched upon some things that I had to deal with. So I was one of the very unlucky few who had most of the severe symptoms, the suicidal thoughts, the joint aches, it was just horrendous. So my next question to you is, what are the hormones that are involved with this condition, and why does it affect us in such a way?
Okay, so it's $1 million question, because there's not enough research, but there are multiple factors really involved in it. But the reason when we're thinking about PMDD is, why the focus is more on the emotional and the cognitive symptoms, is this really the issue is with the brain rather than with the hormones or with the ovaries. It's not a condition of hormonal imbalance. It's a condition of kind of overreactivity or abnormal reaction to normal hormonal changes. So it's the brain's reaction to the menstrual cycle that is the issue, rather than the menstrual cycle per se. And so there's a lot of misinformation out there saying, oh, it's not enough estrogen, or it's not enough progesterone, or it's, things like that. But actually, all the research shows that it's more to do with the brain's response to the changing hormones. And with most people, it's the withdrawal of the estrogen and the progesterone in the late luteal phase of the menstrual cycle. Sorry.
You've just said something there that's completely blown me away. You said that this isn't a hormonal imbalance, but including my doctor, all of the information that I've received is that this is a hormonal imbalance. So this isn't
It's not a hormonal imbalance, no. Sometimes conditions of hormonal imbalance, so for example, polycystic ovarian syndrome, PCOS, where there is a slightly different hormonal profile from somebody without PCOS or with a thyroid dysfunction, then we could say, well, yes, there can be hormones that can exacerbate things in the premenstrual phase. But hormone levels in women with PMDD and PMS are normal most of the time, unless they have other conditions. So it's not about a hormone imbalance, it's more about the way the brain reacts to a normal menstrual cycle. So in the normal menstrual cycle, on the first day of your period, hormone levels are naturally low. And then over the course, say if you had a regular 28-day cycle, estrogen levels increase over the cycle and they peak at ovulation. And then after ovulation, the estrogen drops just slightly. And this can be a little bit of a wobble point for a lot of women. They can feel quite anxious when the estrogen level starts to fall. The estrogen level falling isn't the problem per se. That's what happens if you're born with ovaries, and it's part of a normal menstrual cycle. But the estrogen falls and it gradually, and then it starts to climb slightly before dropping off again. If there's no conception, if there's no pregnancy, drops off again to low levels when your period starts. And at the same time as estrogen dropping after ovulation, if there's no pregnancy, then the progesterone is produced by what's called the corpus luteum. The progesterone levels start to rise. And then the progesterone levels start to rise. Again, if there's no pregnancy, the progesterone levels don't need to stay high. They would only really stay high to try and maintain a pregnancy. They then drop off again. So in the last phase of the menstrual cycle, both the estrogen and progesterone levels drop again until you then have the period and levels are low, and then the whole cycle starts again. And the issue is that the brain has this overreaction or abnormal reaction to these normal changes that we see. It's not to say that hormonal imbalances can't exist with PMDD, but that's not PMDD. And I think where there's this overlap between PMS and PMDD is that all of us, we're all different individuals. Our physiology is different, our genetics are different. A lot of women will notice changes in their physical and mental well-being throughout their menstrual cycle. And I think that's much more common nowadays because we're much more aware that menstruation is like a fifth vital sign. It's a sign of good health if you have regular menstruation. And we can be quite tuned into our bodies, as women. And it's just that you tend to be a bit more aware of changes. So somebody with a PMS would be more, they'll notice more their bloating or the breast tenderness or mood changes. And with PMDD, it's like in many cases, it's an exaggeration of what you would expect. So fluid retention can be huge. I, for example, used to put on half a stone in weight of water retention in the lead up to my period. Whereas somebody without this tendency to a hormone sensitive brain would not have that. So, and whereas mild tearfulness or irritability maybe just part of the female experience, actually being in floods of tears, unable to leave the house because of severe social anxiety, crippling thoughts of just lack of self-worth or suicidal thoughts, that is a very extreme reaction to the disruption in the neurotransmitters in the brain as a result of those hormone changes.
Wow. So when I noticed that something was wrong, sort of my late 20s, early 30s, giving away my age here, my behaviour would change anytime I was like maybe about 10 days before my period. I become really like irritable, the bloating, the the soreness of the breast, the joint aches, and it basically destroyed my relationship that I was in for like many years. So then I started tracking it because I said, oh, something's wrong here, this isn't right. And then seeking assistance from my general practitioner was really difficult. It took 3 years for me to get diagnosed. Initially, they thought I was suffering from depression and anxiety, and I was like, well, I don't think this is depression and anxiety, because when I come on my period, like 2 days after, I'm back to my normal jolly self. Mm-hmm. And then 10 days leading up to it, like I feel like my whole world's collapsing. So eventually I had to go to a private clinician and see a gynecologist who basically diagnosed me within 10 minutes. And they're like, well, you're suffering from this condition and it seems like you have it quite severe because you've got all of the symptoms. Mm. Why is it so difficult to diagnose this condition? And what is the process you recommend for confirming PMDD? Like, are there any specific tests that are required? Or why are women so often just kind of pushed away and told, well, no, you're just depressed, when actually it's something bigger than just, well, depression is obviously quite serious, but it's not depression. It's something completely different. Mm-hmm.
I know, and sadly your experience is so common, and I think back to my own experience being told I'm quite, an oversensitive teenager, and but then that carries on into early adulthood, and people start putting things down to anxiety and depression. And the truth of it is, by the time a lot of women are diagnosed with PMDD, they probably do have concurrent depression or anxiety because they haven't been listened to, they haven't been heard, and it's those ongoing cycles of hopelessness because of the PMDD. And you start thinking, is this me? Maybe I am just depressed, because that's what you're being told. And that's where it can become a little bit tricky in terms of diagnosis. But the frustrating fact of the matter is, it should be a very simple condition to diagnose. There are no blood tests. The only reason we would use blood tests is to rule out other things that may be contributing. Like I mentioned before, is there a thyroid disorder? Is there PCOS? Which these can also have kind of emotional and cognitive manifestations, for example, and things can be worsened in the premenstrual phase. But most of the time those aren't necessary. The only thing that's necessary for diagnosis is tracking symptoms and showing a clear cyclical pattern. There are paper-based trackers that you can get, or you can track things online with apps. There are multiple apps out there now, but you really should just track your symptoms against your cycle for two months at least, to get a clear pattern of what's going on. And if this demonstrates that your symptoms arise after ovulation and improve within a day or so of menstruation, then we can say this is a premenstrual disorder. And if these symptoms are severe, this is PMDD, or we need to treat this as PMDD. I think it doesn't get picked up. I'm hoping things are changing, because there's no teaching on this. Like we don't get taught about this in medical school. I'm hoping that changes. But even, I'm just thinking back to my own, medical degree. There was no mention of this. And I also did further training in gynecology. I did the diploma of the Royal College of Obstetricians and Gynecologists. There was not one question on this in that diploma, and that was meaning that you're a GP with expertise in this area at the primary care level, where GPs are the ones who will see most women who come in with these symptoms. Gynecologists don't get training in this formally either, and psychiatrists in this country don't. And yet the psychiatry are also, it's GPs, gynecologists and psychiatrists are the people who are seeing women struggling with this condition, and there's no general training. And it's only through personal experience or learning through our patients, or perhaps going to a talk where someone who's interested in this topic and manages this condition and they hear about it and then start thinking, oh, that makes sense. So I think I should ask my patients. And the frustrating thing is, it's not difficult to diagnose, and there are guidelines out there by the Royal College of Obstetricians and Gynecologists. So it's a tragedy that it's still happening, that people are not being diagnosed, and then they often develop a secondary mental health condition, partly as a result of their experience of not being diagnosed.
So Why do you think that there is so little research on this, and why, considering that it's quite a serious condition, why are doctors and psychiatrists and therapists not being taught about this condition? Why? Why, like even just personally, I'm doing a research on PMDD, and there is literally no research available, just nothing out there. Why is that?
There is a team of people, particularly at the University of Chicago, and stuff with the International Association of Premenstrual Disorders. Everyone doing research in this area is, will be connected with IAPMD. So there are people starting to work in this area. But I think sadly it comes down to the fact that women's health has often been under-researched and under-invested. And we know, in terms of mental health, again, I think the brutal truth is it's just not a sexy topic. It's not. There isn't. Yeah, I think that's the main reason. And there's two kind of health taboos. It's mental health. It's menstrual health. People are funny about talking about them. So and often there's been this narrative for so long now that it's just part and parcel of being female, or women are just a little bit emotional, and in a way that this would never be. I don't think this would be the same if it was a man with similar conditions. I mean, the way that the last port of treatment for severe premenstrual dysphoric disorder is removal of the ovaries to basically remove the menstrual cycle, even when the ovaries may be perfectly healthy. I don't think if we were removing men's testicles, there would probably be more research. So,
I agree.
I think it's because there's no easy solution as well. There are multiple factors that are at play when it comes to PMDD. And when I talk about PMDD and premenstrual disorders as a whole being umbrella conditions, it's because they don't look the same. So we have guidelines for treatment, but what will work brilliantly for one person will not help somebody else and may make their symptoms worse. And it may be because of what is driving their PMDD. So we know that there are genetic factors at play, that there have been some genes identified in women with PMDD. One of those genes seems to relate to the relationship between estrogen and serotonin in the brain. There's another one which is more to do with the breakdown products of progesterone. So so the breakdown product of progesterone, one of them is called allopregnanolone, and that can often be quite a calming hormone, breakdown product. But for women with PMDD, it can lead to feelings of rage, irritability, suicidality. So if you have a genetic predisposition to this, and your body doesn't deal with the hormones or their breakdown products as it would do in somebody without PMDD, then you're already kind of starting on the back foot. Then together with that, we know that there's a history of trauma, because there are effects on the nervous system, that plays a role as well. So trauma doesn't cause PMDD, but it can maybe be part of the picture if somebody had previously milder PMS and they've got a genetic predisposition to PMDD. It may be the catalyst to kind of tip it, because women with PMDD known to have an altered stress response. So that's been demonstrated in studies, and they don't have the normal cortisol response. And trauma, of course, is going to affect your cortisol response and the stress response. And so there's a big overlap there. They've been shown to be higher levels of inflammation in the body in women who have PMDD. And again, trauma can lead to kind of inflammation on a kind of cellular level. But there can be, if there's other things going on that lead to kind of increased inflammation, that can worsen things for women with otherwise maybe perhaps more manageable PMS symptoms. There have been shown on kind of imaging studies that changes in brain structure and function, but we don't know whether that's a causal effect of the condition. So the longer somebody has had PMDD, for example, this is going to have more impact on the brain. So it's a kind of chicken and egg situation, and it's hard to know what came first.
Can you just, for my own personal understanding, break down why trauma exacerbates, or that there is a possibility that it does, PMDD? Why is that?
We don't know exactly, but we do know that there's an association. And by trauma, I mean it means trauma in the wider sense. So trauma, it could be, the worst kind of, one of the worst kinds of trauma. It could be a history of sexual abuse or physical abuse or something, but
Wow.
it could be bereavement, maybe in the childhood, or being bullied at school. It depends on what, how we're kind of classifying trauma. And I think the sad fact is most people will get to midlife and have had some kind of traumatic event in their life.
Yeah.
And we don't really know what, at least I don't know, and it may be that there is research going on in this, but if trauma kind of again, it kind of like tips the balance. So if you have a genetic predisposition to developing it because you have, altered gene expression in those areas we kind of talked about, that's the one thing that tips things over because of the increased stress on the nervous system. Because we already see that nervous system is affected in PMDD. It's what I would call a psychoneuroendocrine condition. So it's it starts in the brain, but and obviously they say you've got the psyche but also the nervous system, but it is driven by changes in the hormonal um, background. So
Wow. Mind blowing stuff.
mm.
So once I was diagnosed, one of the treatment options that was given to me was to have my ovaries removed, and I was like, absolutely not. I'm just too young. I don't know what the future is going to hold for me, so that's not an option for me. In terms of specific hormonal treatments like prostogen or estrogen therapy, like which ones do you think are effective?
Again, it's really difficult because everybody's an individual and it will very
Yeah.
much depend on what their PMDD picture looks like. So when I'm in clinic, I will look at when the premenstrual symptoms start. Is it just after ovulation, or is it in the few days leading up to the period? So I see quite a lot of girls and women who will struggle around ovulation, then things will settle a bit, and then it will just worsen a lot in the week leading up to the period. Whereas others will just be consistently bad the whole 2 weeks. Others will be just the week before or 10 days before, because that might sometimes give us an idea of what treatment might help them a bit more. But what you're looking to do when you treat PMDD symptoms is either alter the brain's response, so calm down that the exaggerated or that abnormal response to those normal hormonal changes, or to kind of manipulate the menstrual cycle and switch off the cycle. So when it comes to hormones, really, although there's a lot of talk about the use of HRT, so estrogen and progesterone, I personally only see that really being effective when there's exacerbation of premenstrual symptoms in the perimenopause, when HRT would be recommended anyway. It could be that a woman is noticing that her symptoms are just getting worse as she gets closer to menopause and her premenstrual symptoms are tipping into that kind of PMDD category. But in those cases, sometimes all that's needed, but HRT can be enough to kind of stop the wild oscillations of perimenopause, which are exacerbating those symptoms. HRT that does not suppress the menstrual cycle in younger years, when you're nowhere near menopause, is not massively effective from what I can see. And looking at the research, we don't have enough evidence. But actually, if you use hormones to suppress the menstrual cycle, so with certain combined pills, or you use, sometimes you can use the Mirena coil and as the
Yeah.
progesterogenic part and have higher levels of estrogen. Sometimes that works, but again, I find that more helpful in perimenopausal women than younger women. Um, so it really depends on how you're using the hormones. There isn't enough evidence to say, well, you need a high dose of estrogen or you need a high dose of progesterone. What works for one person doesn't work for somebody else, and there will always be exceptions. So I do have some patients who will do quite well on just progesterone only therapy, but for most women that will make their symptoms worse. I have a lot of women will feel better with more sufficient levels of estrogen, but some women that will make them feel worse. So I think that one of the hardest things about it is that it's very much trial and error. It's just important to work with someone who understands the condition, and say what you're trying to do is stabilize those hormonal fluctuations, and reduce the brain's response to those fluctuations.
Okay. What are SSRIs?
So they are a type of antidepressants. Serotonin, reuptake inhibitors,
Right.
and there is actually, this might surprise people, but there's more evidence of benefit for their use in managing PMDD than there is
Right.
for hormones. Um, and I think the reason that there's a lot of people don't understand this or know this is because they may have been offered SSRIs, but it's often being used for the treatment of depression. So that's what SSRIs are normally licensed for.
Yeah.
Whereas they actually have a particular role when it comes to PMDD, in that they help stabilize the neurotransmitters in the brain when those fluctuations start in the latter phase of the menstrual cycle, and they tend to alter the way the brain metabolizes the hormones. And the difference when they're used for PMDD is that they often work within hours to days, as opposed to having to take them for weeks if you're trying to treat a more clinical depression. And they can also just be taken during the luteal phase of the menstrual cycle. The problem is I see a lot of women who've been treated with SSRIs for years at high doses, taking every day, and that often can lead to negative side effects, and it's not really necessarily going to work. I often start at very low doses because women with PMDD tend to be very sensitive to medication, and you often only need very low doses to get a positive response when using them for PMDD. But I think there's a lot of misinformation out there, but also I understand the reticence of women not wanting to take them when they've tried them for maybe for years, but they've not been prescribed them in the appropriate manner for PMDD.
And what are some of the negative side effects that you can get from taking SSRIs?
Well, they can sometimes that you can get and with any of these kind of psychoactive medications, they can make you feel slightly nauseous when you start taking them and lead to GI upset. That's another, say like diarrhea or something like that. That's why I'd normally say you start with a low dose and always eat with food, for example. They can make you feel a little bit more anxious initially when you start them. In the longer term, they can lead to what we call like emotional numbing.
Right.
They can affect libido, so sexual desire. They can lead in sometimes to weight changes, either weight gain or weight loss. But that's why it's important that women know that they don't necessarily need to take them all the time, but they might just need to take them during that premenstrual phase, and that will hugely reduce the risks of side effects and long-term effects. And I've got many patients who take them just in that short period of time, with no problem. It just takes the edge off all their symptoms. They're able to function normally. And sometimes I've seen women who've tried every hormonal treatment out there, and it's just the luteal phase SSRIs that work for them. But it's a bit of an art as well as a science, because there is, although we've got guidelines, they are just guidelines and they don't work for everybody. It's working out what the person in front of you's had before, what they tried, what are their wishes, all of
Yeah.
that kind of stuff.
I only ask because I know that SSRIs essentially their job there is to block your dopamine receptors, right? If I'm correct, or am I incorrect?
No, they
No?
normally no that no they normally prevent the kind of the loss of serotonin. So
Serotonin.
they
Increase?
increase
Okay.
the levels of serotonin in the
Okay.
brain. And there are some SNRIs which are serotonin and noradrenaline reuptake inhibitors, and they affect the dopamine and the noradrenaline receptors as well. And they should increase things like dopamine and noradrenaline. So they don't block dopamine per se.
Okay. Okay. So I've taken the approach of rather than sort of taking prescription medication from my doctors, I've taken the approach to be a bit more holistic. So
Hmm.
I have completely changed my diet. I minimized the amount of alcohol intake. I really shouldn't drink, in my opinion, but you know, you've got to have a little bit of fun in life. I've changed my diet. I work out. I try and be out in the sun as much as I can, because and I take a lot of supplements as well. Because I just don't, I always feel like, oh God, so if I start taking these things, then I'm probably going to become, my body will become dependent on it. And if I ever want to come off it, it's going to be like a whole process to come off it. And I just don't want to do that. So let me try and be a bit more holistic with things and see how that works for me. Thankfully, it is working.
That's good.
Yeah. What advice would you give, or can you explain the role of like nutrition and supplements such as magnesium or vitamin B6 in alleviating the symptoms of PMDD?
Yeah. So in terms of diet, there is no like PMDD diet, but there is a way of eating that will improve or should improve symptoms, or at least provide good background health, which improves your resilience, which will make everything easier to deal with. And that would be having more of a plant-focused diet, so a very fibre-rich diet, and mainly focusing around whole foods. So, you know, lots of fruits, vegetables, nuts, seeds, beans, legumes, you know, and, you know, if you choose to include some meat or fish in your diet, but that's fine, but it should be kind of more of an add-on rather than the main focus of the diet. And that's because a plant-focused diet really is anti-inflammatory inherently. And if you think back at that, women with PMDD have higher levels of inflammation. Anything that is going to lower the inflammation, including what we put into our bodies, is going to help. And also having a plant-rich, fibre-rich diet helps the health of the gut. We've got the gut-brain axis. So we've got more serotonin receptors in our gut than in our brain. And so how we feed ourselves does affect our brain health. And we know that what makes a kind of a happy gut and brain is again more of those plant-focused kind of whole foods, like minimizing kind of lot of highly processed foods and saturated fat, and like, you know, lots of sugar and things like that. I think the cruel thing about PMDD is that women often will have a lot of cravings for those very foods during the
Yes.
luteal phase.
Yes.
Yeah, and I think the difficulty is it's because you're trying to self-medicate, because having foods that give you immediate pleasure, and then you get a big hit because you have some, you know, a nice big donut or something, or, you know, some French fries or something like that, is because it ups your dopamine levels and you feel better for a bit. And it raises your blood sugar. You just generally you get that feeling of pleasure, but it's obviously only momentary. It's a bit like with people who will drink alcohol during that phase or want more of it. It's trying to self-medicate, and it's because you temporarily elevate those kind of neurotransmitters that are lacking during that, you know, the sufficient levels during the luteal phase. But what people really need to do is steer away from that as much as they can. And it's not to demonize any particular food, it's just planning ahead. And say if you want a sweet treat, it's better to focus on some nice fruits, or like dark chocolate, for example, is going to be better than milk chocolate because it's got a higher cocoa content and the flavonoids and the health benefits that come with that. Um, yeah, so it's I think the difficulty is, again, is that when you're struggling with PMDD, it's hard to be motivated in the luteal phase to eat well or to cook from scratch. All the things we know that can help you. But again, it's about preparing, maybe make batch cooking, or even if you know, get something that's a ready meal, try and get one that's healthier. Not that there are that many healthier ones, but there are ones out there now that are better than they used to be, that are lower in salt and that do, you know, do have the fiber and the decent proteins and stuff like that. So yeah, diet is important, but I never really want to give the message that diet will cure stuff. It's a good supportive thing to do. It will improve things. And but the message is really more plants is better. The dairy can be very problematic for some women. And it's if the number one food that seems to aggravate things would be dairy, from my clinical experience and from looking at, you know, case reports and how people tell me as well. And it's because there's thought to be inflammatory, there's the A1 casein in cow's dairy that seems to be particularly problematic for women with PMDD. Um, but again, it's very trial and error. But I'd say if you can replace cow's dairy with fortified soya milk, which also has health impacts on your bones and your heart, and helps your body metabolize hormones better as well. So I mean, there's a whole other thing we could talk about more about the gut, but it's
Wow.
even the way you eat, it helps your body kind of metabolize hormones in a better way. So you're less likely to have hormonal fluctuations if you have a fiber-rich diet than if you eat a standard Western diet, which is very meat and dairy heavy or high in processed foods. And it's all to do with the activation of a particular enzyme in the gut, which helps reabsorb estrogen byproducts. And so that's a whole other thing, but the basic
Wow.
message is the more plants the better. Eat a wide variety of color and type, and even if it's, you start small, if you have like cereal in the morning, add some frozen blueberries or chop up a pear, stir it in, add some walnuts or almonds or something, have those as a snack. Add an extra lettuce leaf or a tomato to your sandwich, and if you make like a beef chili, add, make it half beef, half beans, or add some soya mince instead, or add in mushrooms. It's just trying to get creative and think how you can include more plants in your diet, really.
Wow.
And the alcohol, you're right. The alcohol only serves to worsen. We know it's not good for mental health, but it worsens hormonal fluctuations, which are driving the PMDD symptoms. It can make you feel temporarily good while you have that drink, but the next day you're going to get a crash. It will worsen anxiety, can lead to paranoia. It affects the health of the gut, so it destroys a lot of the healthy gut bacteria. Having said that, being realistic, a lot of people will want to have the occasional drink, and I think it's just being mindful of, if you have a glass of wine, make sure you're having is good quality, that you're having it with food, and that you're in a good headspace. So if you do drink, it may be better to reserve that for the follicular phase. If you are on a downward spiral during PMDD, try not to reach for alcohol, because it will only make things worse. I mean, there is evidence for the exercise, moving your body regularly. Again, it's a bit difficult for women with the most severe PMDD because they can feel so depressed. They may be struggling with the physical symptoms, and it might be about switching up your exercise regime to do more supportive things. So rather than a high intensity weight class or something, maybe going for a walk in nature, doing some gentle yoga online. Those things might be better. But it has to be something that works for you. You mentioned getting out in the sunshine. Again, the sleep-wake cycle can be really disrupted during PMDD.
Yes.
And it's the effects of the hormones on the brain, and the pineal gland and melatonin production, and trying to kind of get up at the same time each day and getting exposure to early morning light is important. And it's hard in winter, isn't it? But like even sitting near an open window, with light, or having a bright light like SAD lamps that we use for treatment of seasonal affective disorder, so you get light at the back of the eyes, is going to be helpful.
Um, so wow, I'm just mind blown by all this stuff, because I'm just like, oh my God, I'm learning so much. I used to be a vegan. Between the years of 2018 and 2021, I was a vegan.
Mm-hmm.
And during that period of time, I never suffered from this. Well, I don't know if it was dormant. It was never there. I was fine. I had the normal symptoms of PMS like most women do, but it never bothered me. I stopped being a vegan in end of 2021, moving in 2022. And that's when all of these kind of problems started for me. So you mentioning about gut health and eating more greens and more plants, it makes complete and utter sense. And now I'm reconsidering my whole, do I go back to being a vegan? Maybe, considering I have this condition, I should. But yes, thank you. So another question that I was going to ask you was how PMDD interacts with other conditions like anxiety, depression, and should treatments be adjusted accordingly, or?
Yeah. So Yeah, it's an interesting one, and this is an area that's hugely under-researched as well. Is that there is a category of conditions called premenstrual. We term it premenstrual exacerbation, or PME, and this is where there is worsening of a pre-existing condition during the premenstrual phase, and it can be quite important to differentiate: are we dealing with a worsening of depression or anxiety, or is this true PMDD? And the difficulty, as I kind of alluded to before, is that they can coexist. You can have depression and you can have PMDD. And also the premenstrual exacerbation could be something like ADHD symptoms, for example, as well, or it could be OCD, intrusive person, but it can also could be physical symptoms. So, like you mentioned, endometriosis, or it can be I don't know, migraine, things like that can worsen. And the way that you kind of differentiate what's going on is by tracking. So if somebody has PMDD in isolation, so they're generally very well, have no past medical history, it could be, say, a young woman, early 20s, but notices for 2 weeks a month they just don't recognise themselves, they feel horrendous, they feel that they can't cope with the life. And then the period comes and suddenly the sun comes out again. Then that would be kind of PMDD. But it may be that someone has, that maybe they were diagnosed with anxiety when they were younger, but they noticed that their symptoms get much worse during the luteal phase, and so their symptom never really goes back to baseline. They've always got some level. That's a bit more premenstrual exacerbation. Sometimes I think it's a little bit of a false dichotomy when it comes to the mental health and emotional symptoms, because so many young women have been told they've got anxiety or depression, and it may often have been around their cycles, but that was never picked up, and they've been given this label of having anxiety or depression in the past. That's one of the difficulties. And actually, the guidance really is, if there's an underlying condition that is being worsened, so maybe it's ADHD, or maybe it's OCD or migraine, you would work to optimize the treatments of those, to make sure that they're as well controlled as they can be. I've got a lot of patients who also have ADHD because there's a link with the neurodivergent brain and PMDD.
Oh,
Um,
wow.
and and often they will have already worked with their psychiatrist to optimize their ADHD treatment. They might need, for example, to increase their ADHD meds if they're on them during that luteal phase, but it may be that their ADHD symptoms are better, but they still suffer hugely low moods, or some of the other symptoms. And then we think, well, what we'll work on then is their PMDD. We need to look at the role the cycle's playing, and so then that goes back to, do we go for cycle suppression, or do we use some other medication, or to help affect the brain's response, or do we look more at changing their lifestyle, giving dietary advice, things that will help both potentially the ADHD or whatever else is going on, but also the PMDD. So the standard line is work to optimize the treatment for the condition we know exists, and then focus on the PMDD. But I do see a lot of women who have potential ADHD, for example, or something else that is going on. And if there's a cyclical worsening, then we're not going to do any harm by treating those cyclical symptoms as PMDD. And then we can kind of see what's left. And you think, okay, so maybe you still get migraines, but things have got a bit better. But maybe we need to look more at managing those, taking out the hormonal aspect. So that it is important to kind of work out, is there something else going on as well? But most of the time I find if you can improve the PMDD symptoms, the underlying condition also improves if it's being worsened by the menstrual cycle. And it comes down to tracking, because if somebody just has symptoms throughout the month, then it's probably not really driven by the hormones, it's there. Or, like, again, migraines are quite a good example. If they've got migraines during the follicular phase, and there's no difference in frequency between that and the luteal phase, maybe manipulating the menstrual cycle isn't going to make any difference. But
Wow. You mentioned neurodiversity and there being a link
Mhm.
between PMDD and neurodiversity. So I'm neurodivergent myself.
Mhm.
Why is there a link between neurodivergency and premenstrual dysphoric dysfunction? Is it to do with the hormones? Why? Why is that link there?
I don't think there's enough research. We just know we're seeing more and more that there are more women with ADHD or a diagnosis of autism who are also the ones who are struggling with the severe premenstrual symptoms. And I think, well, for example, with ADHD, then there's often a heightened sensitivity, and we see this in autism as well. You're hyper aware of things, with the ADHD brain, which is incredibly busy, and you can never control things. That can go kind of haywire during the premenstrual phase, and already there's a heightened sensitivity to that. You're easily distracted, that kind of thing. It's just I feel that people who have a neurodivergent brain, they're already kind of highly sensitized to their environments, and PMDD is another form of sensitization. The way I see it, you're incredibly sensitive to those hormonal swings. So sometimes I will say in clinic, it's a bit like if you're thinking about the volume on a radio. So women without the neurodivergent brain, without PMDD, the volume on their signals from their body will go up and change with the menstrual cycle. So maybe in the follicular phase, it's like a background low level 2. Maybe it goes up to 3 or 4 during the premenstrual phase. When you're living with ADHD or autism, you're probably so much more aware, maybe not consciously, but you are more stimulated by your environment. And so your volume is up at, say, 7 or 8 anyway. When it gets to the premenstrual time, it's 10 plus. So, and I suppose the way you want to manage, treatment is kind of turning down the volume on the brain and giving the signal back to the body and mind. You don't need to overreact. This isn't an alarm. It's not an emergency, because I don't know. This isn't a very scientific explanation. It's just the way I kind of describe it. Because there's also a link with connective tissue disorders like Ehlers-Danlos syndrome and hypermobility as well. And then again, with Ehlers-Danlos syndrome, there's associations with anxiety and neurodiversity. So these often come together. You'll see women living with hypermobility, anxiety, ADHD, and PMDD. But I think it's the body is in a sensitized, and the mind are in a sensitized state, and it's luck of the draw really with genetics, but environment play a part as well.
Looking ahead, are there any new emerging treatments for PMDD in the UK that we should be aware of? What is being done?
Well, look, the message is, because I know it's probably quite overwhelming, some of the things we've discussed, and there's so many factors, and I don't want people to come away from with the idea that there's it's too tricky, there's nothing that can be done. The good news is there is always stuff that you can do to improve symptoms. So you yourself have found that even making some dietary and lifestyle changes can have a huge impact, and I would encourage everyone to do that. But for some people with very, very significant symptoms, it just feels impossible at that time of their month, and they may need further medical intervention. And what works for one, as we said, won't work for another. But there are the psychoactive medications, as we discussed, the hormonal medications. Different things will work for different people. We want to ideally avoid having to go down the route of chemical menopause, where you switch off the ovaries, or surgical menopause. Sometimes, though, that is necessary, and sometimes it's life-saving. So I don't want people to think that, and then that they shouldn't do that if that's right for them, but they need to be under the care of someone who understands that and guides them through it. Also understanding removing the ovaries doesn't change the hormone sensitive brain. You still have that brain that's very sensitive, but it just gives it a break because you take away the driver for the menstrual cycle there. Psychological therapies, there is evidence that CBT and DBT can be helpful. But again, you need working with somebody, a therapist who has understanding of the nuances and the hormonal fluctuations. And it's not quite as simple as just reframing, having positive thinking. This is not what this is about. It's about learning strategies to help manage crises. But also, if you can learn to manage very difficult emotions or have some tools, that again turns down that dial, that stress response, which helps calm down that the body and mind in PMDD. EMDR therapy for history of trauma can be helpful. But in terms of new treatments, Well, there is actually some new exciting stuff on the horizon, which we're just starting to look at a bit more, which is neuromodulation. Have you heard of this?
I haven't heard of neuromodulation, no.
So it's transcranial direct current stimulation. And there are now two devices that are available, which you can purchase, but some of them are available on the NHS in different parts of the UK. And they're essentially medical devices that are worn on the head like a headband. Okay, so there's there and they what they do is they produce a small electrical current. This is not like electroconvulsive therapy, which people might be aware of when people have, severe electric shocks to induce seizures when people have like life-threatening depression. It's like very, very, very low level electrical current to the frontal cortex in the brain. And what this does is it stimulates neural activity in areas that are underactive during the luteal phase, and downplays, neurons that are overactive during the luteal phase to kind of mimic the follicular phase of the cycle. And it seems we're seeing a lot of good response with that. So there are some trials going on at the moment looking at the use of this technology in women with PMDD. And it's really, really encouraging because it's a medication-free option.
Yes.
And is that we know that there's evidence of benefit for depression, but we are also seeing that it seems to be helping women with this premenstrual mood disorder because the similar parts of the brain are affected. And it doesn't actually cause neurons in the brain to fire, it just makes them more likely to fire. So it creates a more positive environment, and improves positive connections while reducing negative connections in the brain that can lead to downward spiraling of mood. So there's two devices in the UK. There's Flow, which is licensed for clinical depression, and then there's Nettle, which is developed specifically for premenstrual symptoms, and also has a part which acts on the back part of the brain responsible for pain. So some women are finding it helpful if they get bad period pain as well. So I can send you the information on them, but if you
Yes,
wanted to link, but we're just looking at
absolutely.
that. So
We can link it all down below here for
yeah.
our viewers. I think I have one more really important question in my opinion. What can we do as women who suffer from these conditions to help assist in changing policies for just general life, like at work, at schools? Because I feel like, for me certainly, it doesn't get taken seriously. People just think that, oh no, you're just suffering from your periods, you're fine. When actually, for me at least, is a complete and utter shutdown of your body. Just your physical and your mental, just a shutdown. And this lasts for a really long time. I mean, 10 days is a huge chunk out of the month. So how do we move forward and help to change policies so that we're taken seriously, so that this is looked at more seriously, and that there's more funding for more research? What do we do? I just feel so helpless sometimes.
I think keep talking about it. So I suppose doing this hopefully will help get a little bit of awareness in terms of it, because I think every person who learns that maybe that their moods are affected, by their cycle and linked, it can be a bit of a light bulb moment. Also knowing that there's treatment, that's going to help people on an individual level. I personally do teaching, so I'm teaching at the Royal College of Obstetricians and Gynecologists like later this year. I teach GPs, and hopefully I have seen in the last few years that more and more GPs are becoming more knowledgeable, more skilled. They're aware of guidelines. So the more we talk about it as healthcare professionals, the more you talk about it, everyone out there in the community, people are affected, is going to help. It's going to have a trickle effect. The way to change policy, sadly, is just to show how it hurts people economically. That's the only way I see that things change on a deeper policy level. But there's good reason why we need to do it from the society point of view, because this does impact the workforce. It's a bit like with menopause. We see 1 in 10 women leaving the workforce due to menopausal symptoms. You've got 1 in 3 women with PMDD who suffer with such severe symptoms that they contemplate or attempt suicide.
I was one of those women.
I'm so sorry. I think it's just so.
Yeah.
This is a devastating disorder,
Yeah.
and it's not taken seriously. I think there is a lack of awareness, but I think when people are suffering so much, they're not able to function well, for part of the month, which means that a lot of the women I see work for themselves or work part-time or flexi working because they can't manage to hold down a full-time job because their symptoms are so severe, or they feel that they're not taken seriously, or they're just told, oh, everyone gets a bit of PMS. So I think talking about it is going to help, but in terms of maybe speaking to MPs, writing to them, finding out a bit more about the statistics about how many are affected. So I think we don't have enough information really on how many people are affected in the workforce, but if you know that over 5% of women have this condition, and that a third of those are so severe that they're actively suicidal, it's not an insignificant number. It's hundreds of thousands of women, isn't it? At least. My math is not very good this morning. But so I think it's focusing on that. In terms of educating, I mean, offering to go into schools to talk to girls and to let them know that this isn't normal and to get help. Not to scare people, but just to say what you need to do is track your symptoms, directing to resources. So there's the National Association for Premenstrual Syndromes, NAPS, in the UK. There's the International Association for Premenstrual Disorders, IAPMD, in the US, but they're global.
Yeah.
There's lots of good resources out there. IAPMD's website sadly is down at the moment, but they've got brilliant resources on there. So when they're back up and running, definitely look at that. Mind has quite a good, the mental health website, that's got a good section on PMDD. So things are changing slowly. I think we just have to keep talking, shouting, writing about it. There was the BBC did a little story on it at one point, and that really kind of opened the floodgates. Lots more people suddenly recognised themselves, and so anything that you can kind of do, if you worked in, you trained as an actor and stuff like that, any connections you've got kind of in the media will be helpful. So
absolutely.
Pressure journalist friends and say you need to talk about it, because that's where we get. So there have been some recent articles in, say, the Times and stuff, and again that just does everything to raise awareness. So
yes, I am trying, and I will keep trying to raise as much awareness as I can to create some sort of change, so that the generation after us, after me, have an easier time. Dr. Anishul, I want to thank you so much for taking the time out and coming here to speak about something that is so important and so close to my heart. And you have been incredible. Just before we go, if people want to reach out to you, how do they reach out to you? Do you have a website? Is there an email you can give out? What is the best way to get in contact with you and find out about the work that you do and your research?
Well, I have a website, so it's just drhannahshort.co.uk, but I can send that to you. I don't have an email that I give out just because I cannot give direct kind of medical advice. It's not safe. I'm not insured to do that. But I have got resources on my website, including like PMDD, so other podcasts, but also links to guidelines and things like that. I work with part of menopause care, but under menopause care we see a lot of PMDD patients and stuff as well. There's some information on the menopause care website. So I'm not on any social media at the moment because life is I was for a while, but it's very hard. I found it hard to keep up with that and my work and writing, and I'm hoping to write, in the process of starting to write a book on PMDD. So
amazing.
You can kind of watch this space. But,
yes. Well,
so
do let us know once the book has been released so that we can all read it and tell people where to find it. We'll make sure to link all of the information that you've given us down below so we can get in contact with you via the website. Thank you so much. You have an incredible day. It's been amazing. Thank you.